Okay, so thank you very much for inviting me and good morning to all of you here. So I have been told to talk on pulmonary function test for the next 17 minutes. And in most of the cases, spirometry is often equated with pulmonary function test. But as you can see, it is not so because apart from spirometry, there is a whole gamut of tests which involves pulmonary function tests. And to speak on all of this in the next 17 minutes would not be possible. So what I can do is I can only give an overview of all the tests which are listed here, not a comprehensive list, but a near complete list. And so we start with the commonly performed test and the most easy to perform test. So this is peak expiratory flow rate measurement. So what we need is we just need a small device which is called as a peak expiratory flow meter, and we ask the patient to blow as rapidly and as deeply into it as possible. And we take 3 measurements and the best of it is taken as the reading. Why it is used? So it can be used for diagnosis of asthma and it can be used to monitor the control of asthma. Now spirometry is needed for diagnosing asthma, but if spirometry is not available, then if there is a history of variable respiratory symptoms, then we can use peak expiratory flow rate to help us to diagnose a case of asthma. So like if suppose a patient comes to me, I have suspected asthma in him, I do not have spirometry, I do a peak flow, and after few days when the patient comes back to me, I again repeat that peak flow, and if there is a variability of more than or equal to 20%, then it suggests that patient has bronchial asthma. So this is the way we can use peak flow for diagnosis, and even it can be used for monitoring. Like if we monitor serially the peak flow rates of that patient, and if it falls, then we know that the patient is at a risk of exacerbation because peak flow falls before the patient perceives the symptoms. And then if the peak flow is less than or equal to 50% of predicted, then it indicates severe exacerbation. What are the disadvantages? Peak flow, it is effort dependent. Patient has to blow really hard into the device. If the patient does not blow that hard, then what your results will be falsely negative. So it is an effort dependent test, and the values vary with the device which we are using. So that is the disadvantage of peak flow meter. So now next come to spirometry, most commonly performed test. We all know what is spirometry. Patient has to take a deep breath and then blow as deeply, as forcefully and as deeply as possible. And then patient has to keep on expiring till the end of his breath and then has to take a deep breath. So that is spirometry. What we can measure is dynamic lung volumes. That is FEV1, FVC and FEV1 and FVC mainly. So based on that, we can classify into obstructive diseases or restrictive diseases, and contrast it to this forced oscillometry. Not really a nice term, not forced oscillometry. We should ideally call it as lung oscillometry. What the patient has to do, he has to only take tidal breaths into the device. What happens is pressure waves in the form of sound waves are forced into the airway of the patient, and then the reflected waves are collected back and analyzed, and through that we get the impedance of the respiratory system, from which we can derive the resistance and reactance of the respiratory system, so that we can get an idea of the airway resistance and also the elastance of the lung. So as you saw that in forced oscillometry, patient does not really have to blow hard. So what is the advantage of lung oscillometry? If the patient is not able to perform spirometry, then we can use lung oscillometry or forced oscillometry, like children, elderly or mentally retarded patients who are not able to follow instructions during spirometry. In those cases, we can use forced oscillometry. So this is a simple interpretation of spirometry. First, we look at FEV1 by FVC. If it is more than lower limit of the normal, or more than 70% of more than 70%, that means patient either has a restriction or has a normal spirometry. So to look for restriction, we will look for forced vital capacity. If forced vital capacity is less than 80% of predicted, that means patient has restriction. If forced vital capacity is more than 80% of predicted, that means patient has no ventilatory defect. If FEV1 by FVC is less than lower limit of normal or less than 70%, that means patient has obstruction. So you look for FVC. If FVC is more than 80% of predicted, that means patient has pure obstruction. But if FVC is less than 80% of predicted, that means patient also has restriction along with obstruction. Now you cannot confirm restriction with spirometry. So to confirm restriction, we will have to do what is called as body plethysmography to estimate the lung volumes. So this is a report of a spirometry. If you can see FEV1 upon FVC, it is 55 pre-bronchodilator, 67 post-bronchodilator. So less than 70, that means patient has obstruction. Next, you see FVC. FVC is 101% predicted. That means there is no restriction. Patient has pure obstruction. Correct? And as you can see, the flow volume loop, it is scooped. That just gives me an idea that patient has obstruction. So this is a spirometry of a patient with obstructive ventilatory defect. Now once you have obstruction, we see what is called as bronchodilator reversibility. So you give a bronchodilator, a short acting bronchodilator like a salbutamol, 100 microgram 2 to 4 puffs, wait for 20 minutes and then repeat spirometry. And what we see improvement in FEV1 or FVC. So if the improvement in FEV1 and or FVC is 200 ml and 12%, or maybe according to recent ATS guidelines, even a 10% improvement is considered a good bronchodilator reversibility. A good bronchodilator reversibility is suggestive of bronchial asthma, but it can also be seen in patients with COPD. And this is a report of forced oscillometry. So what parameters we get in forced oscillometry? R5. R5 is resistance at 5 Hertz. So the sound waves which are traveling, the sound waves which have a frequency of 5 Hertz. So the waves which have lower frequencies, they travel farther. So that is the reason why R5 represents total airway resistance. R20, higher frequency, they won't travel farther, they will travel only up to the central airways. So R20 represents proximal airway resistance. And if we minus R5, R20 from R5, we get what is called as a distal airway resistance. Now I am not using the term small airway resistance because theoretically, small airways are airways which are less than 2 millimeter in diameter, and R5 minus R20 does not represent only small airways. It also represents airways which are beyond the 7th or 8th generation, which also have muscular walls. So R5 minus 20 is not in true sense an indicator of small airway, but of distal airway resistance. And there is something called as AX and X5. They represent the elastance or the lung compliance component of the forced oscillometry. So generally for interpreting, if we go to spirometry, we used percentage predicted values. That is because FEV1, FVC, they depend on age, height, gender and ethnicity of the individuals. While as far as forced oscillometry parameters are considered, they do not depend more on age or gender of the individuals, maybe on height, but they do not vary with age or gender of in adults, not in children. So that is the reason why we usually use cutoff values. Now cutoff values do vary with devices, but as a rule of thumb, currently, since we do not have cutoff values for all the equipments which are present in India, what we use are the cutoff values which have been developed for the Antilla device. So R5 more than 4 is suggestive of increased total airway resistance. R20 more than 3 suggestive of increased central airway resistance. R5 minus 20 more than 1 is suggestive of increased distal airway resistance. And AX more than 4, X5 more than minus 1, they are all suggestive of increased elastance or compliance. So this is another spirometry. Again, FEV1 by FVC 43.12, FVC percentage predicted 53%. That means there is obstruction along with restriction. And FEV1 is 33% of the predicted, 37% predicted in post bronchodilator. So what is our interpretation of this spirometry? Obstruction with possibility of restriction. And to confirm restriction, we will do lung volume estimation. So lung volume estimation can be done by many methods. One is body plethysmography, one is helium dilution or inert gas dilution, and one is nitrogen washout. The most accurate, gold standard, and probably the most expensive and the most fastest is body plethysmography. Body plethysmography will give you lung volumes in 2 to 3 minutes. Helium dilution, nitrogen washout will take 7 to 10 minutes. So body plethysmography is the most accurate one. So this is a report of body plethysmography. So what you want to look for? TLC, total lung capacity. So if the total lung capacity is decreased, so now for all practical purposes, 80 to 120% of predicted is normal. So anything less than 80% of the predicted is restriction. So if you see TLC is 102% predicted. In spirometry, we said obstruction with possibility of restriction, but on body plethysmography, we see that TLC is 102%, so it is normal. So there is no restriction. So what in spirometry we got was pseudo restriction. And why was this pseudo restriction? You look at RV, residual volume is 177% of predicted, highly increased. So that pseudo restriction was due to air trapping in a patient of COPD. So that is the reason why we need body plethysmography to confirm diagnosis of restriction. Another case, FEV1 by FVC 23.42, FVC 64% of predicted, again obstruction with restriction, and see what is there in body plethysmography. How much is the TLC? 123% of predicted. So an increased TLC is suggestive of hyperinflation. Again, the restriction which we saw in spirometry was pseudo restriction because of hyperinflation. Patients of COPD are not able to expire all of the air. So some of the air always remains in the lungs, which increases the residual volume, and over a period of time, as the severity increases, even the TLC increases. That leads to pseudo restriction in these patients. And then in such cases, you can even use total lung capacity to monitor for treatment. Like in some patients of COPD, you start bronchodilator therapy. There may not be any change in FEV1 or FVC post-treatment. But if you do their body plethysmography, you see that the TLC has reduced, RV has reduced post-treatment, suggesting improvement, suggesting that now hyperinflation or air trapping has decreased or resolved. And then this is how body plethysmography is conducted. So the patient has to sit in a body box. I won't go into the physiology or the pathophysiological details of the test, but then patient has to sit in the box and he has to do normal tidal breathing, and then he has to pant, during which the shutter closes and pressure and volume are measured. And that is how you get what we call as TGV, thoracic gas volume, which is equivalent to FRC. And then you also do a FVC maneuver in this procedure, from where you get your ERV, and then RV TLC are calculated. So during body plethysmography, the patient has to pant. Many patients are not able to do that. During spirometry, forceful effort is required. Many patients are not able to do that. So what we have is airway resistance by interrupter technique. What the patient has to do? Only he has to do tidal breathing. Once good tidal breaths are achieved, the machine will do a automatic shut off, so that mouth occlusion pressure is measured. Mouth occlusion pressure is equivalent to alveolar pressure. Resistance is pressure upon flow. So once you measure the pressure and flow, you will get airway resistance. So that is airway resistance by interrupter technique. Patient does not require a lot of effort. Disadvantage is not a widely used technique, so we do not have standardized measurements, we do not have standardized values, but then we do get a fair idea that patient has increased airway resistance. So if you see ROCC, it is 226% of predicted, that means it is increased. So one thing which I missed was in body plethysmography also you do get resistance. This is raw total. You see 1467% predicted, and S raw, that is specific airway resistance, 2195% predicted. S raw is resistance which has been adjusted for volume. So even in body plethysmography, you do get values of airway resistance. So when they are highly increased, 500 to 1000%, that means airway resistance is increased. Again, this is a report of forced oscillometry. R5 6.99, more than 4, that means total airway resistance is increased. R20 more than 3, so there is central airway resistance. R5 minus R20 2.70, that means there is also distal airway resistance. AX highly increased, more than 4, it is 90.26, and X5 also more than -1, it is -7. So this is a case of obstructive airway disease, and since AX is so markedly increased, probably it is a case of COPD emphysema. And if you see, now these are in development parameters, very new parameters. X5 inspiratory -6, X5 expiratory -9. So expiratory is more than inspiratory. That means that confirms that this is an obstructive airway disease. Had it been a restrictive lung disease, this would have been reversed. X5 inspiratory more than X5 expiratory. This is another case of forced oscillometry, another case of COPD. Now, with spirometry, we can also do bronchodilator reversibility in forced oscillometry. And what we see is AX. A decrease in AX by 80% and a decrease in R5 by 40% is suggestive of a good bronchodilator reversibility. And then there is something called as diffusion lung capacity for carbon monoxide. So what happens is the diffusion of gases, it occurs at the alveolo-capillary membrane. So any pathology which involves the alveolo-capillary membrane will result in restricted diffusion of carbon monoxide. So that is what we measure during the DLCO test. Normal DLCO is 25 ml per minute per millimeter of mercury. In this patient it is 19. So that means it is decreased. So that suggests that there is some problem at the alveolo-capillary membrane. And this was a case of COPD. COPD, we know that there is destruction of the alveolar walls. Also, there is pulmonary hypertension. So, there is reduction in DLCO. If you see KCO, KCO is also decreased. So, KCO is also decreased. That means there is additional capillary damage, probably due to pulmonary hypertension, which has resulted in low DLCO in these patients. This is how a DLCO is performed. So, patient has to sit with a mouthpiece in his mouth, and he has to initially he has to do normal tidal breathing, and then he has to expire, take a deep breath, do a breath hold for 10 seconds and then expire. So once the patient inspires, the gas mixture which contains helium and carbon monoxide, the patient inhales it. During breath hold, there is equilibrium attained, and there is diffusion of carbon monoxide, and when the patient expires, this expired gas is collected by the gas analyzer, and from that we get the values of DLCO. Now DLCO is most useful in patients with interstitial lung disease. So if you see, this is a case of ILD, FEV1 by FVC 84, more than 70, that means it is either normal or there is restriction. FVC is 31% predicted, that means it is possibly restriction, and then we confirm it via body plethysmography. So if you see TLC, how much is the TLC? TLC is 49% of predicted, less than 80% of predicted, so it confirms our restriction. So once you know restriction, you want to know whether it is a parenchymal restriction or a extraparenchymal restriction, for which you see RV. So if RV is also reduced, that means it is a parenchymal restriction. You also look for FRC. If FRC is also reduced, again suggests parenchymal restriction. If RV is preserved, that means there is extraparenchymal restriction like neuromuscular disease or kyphoscoliosis or chest wall disease for that matter. And so this is what happens to DLCO in patients with ILD, 36% of predicted, highly reduced. And there is something called a 6-minute walk test, a form of field walking tests. So field walking test includes 6-minute walk test, shuttle walk test, 1 minute sit to stand test. Most commonly or most standardized is the 6-minute walk test. What you want is only a 100 feet corridor or a 30-meter corridor. Patient has to walk for 6 minutes. And what you monitor pulse, BP and SpO2 and the distance which the patient has walked. Useful for prognostication. What we look at is 6-minute walk distance and how much he has desaturated. So this was a 36-year-old female, case of systemic sclerosis associated interstitial disease. How much she walked in 6 minutes? 253 meters. How much was she expected to walk? 498 meters. So almost 50% reduction, and there was a 36% desaturation, 99 to 63%. So that shows that she had interstitial lung disease, and on that, in addition to that, probably she had pulmonary hypertension. That is the reason why she desaturated so much. And then there is also growing interest on the role of forced oscillometry in patients with interstitial lung disease. So what happens is R5, R20, R5 minus 20 will remain nearly normal. What will increases AX and X5. And as we said, X5 inspiratory will be more than X5 expiratory. Now I will just take you through a case in 1 minute. So this was a 65-year-old woman who came to us with progressive exertional dyspnea, and she also had symptoms suggestive of proximal muscle weakness. She was not able to get up from chair. She was not able to get up from squatting position. And on examination, we found that in addition to bilateral fine and inspiratory crept, she also had proximal and distal muscle weakness. There was no cranial nerve involvement. Creatinine kinase was elevated. We suspected myositis. We did a whole body MRI for myositis screening, which was also suggestive of muscle inflammation. ANA was positive. ANA blot showed anti-coup positive. Spirometry restriction, lung volume estimation, confirmed restriction, parenchymal restriction, DLCO was greatly reduced. But since it was a case of myositis, we also thought probably patient also has respiratory muscle involvement, and that is the reason why we also did respiratory muscle function assessment. And the tests which are used are MIP, MEP, P.1 SNP. So what is P.1? P.1, it is the how much the patient can generate pressure at the mouth, negative pressure at the mouth at 0.1 seconds. So it is an indicator of neural drive. In this patient, P.1 was 522% predicted, highly increased. That means patient had high neural drive. But look at her MIP, PI max 50. Anything less than minus 70, anything less than 70 is reduced. Look at PE max 45, anything less than 60 is reduced. So and the best one is SNP. SNP was 30, less than 70 is reduced. So patient had respiratory muscle weakness, and she had an increased respiratory drive. That means accelerator was being pressed, but the muscles were not responding. So that was suggestive of neuromuscular disease. And then we also did an ultrasound diaphragm, and what we saw is the diaphragm, though the tidal excursion was normal, during deep breathing and sniff, the excursion was reduced, confirming diaphragmatic involvement and expiratory muscle involvement. And then during follow-up after 3 months, we repeated her MIP, MEP, SNP, and if you see, MEP has increased from 50 to 55, even MEP has increased from 45 to 50, and SNP has increased from 30 to 45, suggesting good response to immunosuppressants and steroids. And then this is CPET. I don't think I would be able to cover very complex investigation. We get a lot of parameters. Indication is to evaluate a cause of unexplained dyspnea and for giving fitness for lung resection surgeries and for heart transplant. And then we have phenofractional exhaled nitric oxide, which is an indicator of airway eosinophilic inflammation. So to summarize, peak expiratory flow rate measurement, simplest, can be used for diagnosis if spirometry is not available. Spirometry is required for diagnosis of asthma and COPD and also for assessing treatment response, both in COPD and ILD. Post oscillometry if patient cannot perform spirometry. Lung volume estimation, gold standard for confirming restriction. Field walking test, 6-minute walk test, most commonly used mainly for prognostication. Respiratory muscle strength assessment, not required in all, only when you suspect neuromuscular diseases or diaphragmatic involvement. Pheno for phenotyping severe asthma. Now there is something called as airway resistance by interrupter technique, not widely used, but can be done very easily by patients who cannot do spirometry or body plethysmography. Bronchial provocation test I did not touch upon, but rarely used these days, especially when we have forced oscillometry and airway resistance by interrupter technique. And then we have cardiopulmonary exercise testing. Main indication is to evaluate a cause of unexplained dyspnea. So thank you very much.